Dr. Natalie Kiel. Welcome to the Talking Gut
Hi.
podcast.
Thanks so much for having me, Jim. Good to be here.
So awesome to have you. I've been wanting to have you on this show for some time, so it's cool that you're here at my constant persistence. And for listeners who clearly don't know, Dr. Kiel and Natalie and I know each other. So it's absolutely wonderful to have you on board to talk about a topic which is something that is so common, so general. And a lot of us don't give it a second thought, but I thought it'd be great for people to know exactly what's involved in this area or this procedure that we call endoscopy. But before we start, all my guests, we've also started by finding a little bit about them, because I'm always kind of curious what leads people to getting to the point where they are. For you as a gastroenterologist and hepatologist, who routinely does obviously colonoscopies and gastroscopies, but how did you? I think I've asked you this personally as well, but I can't remember the answer to tell you the truth. But how did you get to this point where you actually went, I'm going to become a doctor, I'm going to become a gastroenterologist?
Um, I decided that I wanted to be a doctor from when I was 13 years old.
That's right.
Really loved science and I loved talking to people, so I thought I'd do something that put the two together. And I can say that over the years, like that was a very long time ago now that I was 13, but I really worked towards being a doctor from that time. And yeah, over the years, my gratitude for the trust and faith that people put in me at the really most vulnerable moments has really only deepened, and I've just been so grateful that I can do my job. And really, choosing gastroenterology was something that was just kind of a natural progression as time went on. You lean towards what interests you.
Yep.
um, Doing endoscopy is really just part of gastroenterology.
Mm-hmm.
I enjoy it. It's an ongoing challenge. And I've just been fortunate that over recent times that the general population has become so interested in the gut microbiome and
Mm.
realised how important our gastrointestinal health is to our general health.
Yeah. And I think yeah, there's certainly a lot more posts and things out there, and books like The Gut by or Gut by Julia Enders as well has helped
Mm,
significantly.
yes.
Um, in terms of when we so today's topic is about endoscopy,
Mm.
and for people who might be unfamiliar with it, what exactly is endoscopy, and I guess what is the difference between gastroscopy and a colonoscopy?
Endoscopy is simply the examination of the gastrointestinal tract with the use of a camera at the end of a thin, flexible tube.
Mm-hmm.
So the word endoscopy is a general term, and we can call a gastroscopy or upper endoscopy the examination of the upper gastrointestinal tract. Truthfully, the proper name for the upper endoscopy is an esophagogastroduodenoscopy, but it's just too much of a
No,
mouthful.
it's not. Everyone should say it.
And so we might say gastroscopy or upper endoscopy. And then the colonoscopy is the examination of the colon and generally the very last part of the small intestine just before the colon, usually the last 5 to 10 centimeters of the small intestine just before it joins up to the colon.
It's interesting because when I ask patients, have you seen a gastroenterologist, have you had any tests? They say, yeah, I've had an endoscopy and a colonoscopy, and they tend to refer to
Yeah,
the gastroscopy as
as the
endoscopy. Yeah,
endoscopy.
yeah,
Yes, yep.
yeah. So the gastroscopy goes all the way down to where the
To
duodenum.
the yeah, generally the third part of the duodenum. The duodenum is the first part of the small intestine. The small intestine is actually 3 to 6 meters in length.
Mm-hmm.
And when we do that gastroscopy, we just go into the duodenum, which is the first part of that small intestine. And yeah, and it's divided into four areas, but we or four parts, I should say, but we just go down to the third part. Beyond that, it's a little bit tricky to keep going.
And that's because I guess the diameter of the small intestine is smaller, and then you've got all these folds, multiple
It's
folds,
the
and so forth. Yeah.
folds and the angles of the the small intestine, it just becomes difficult to go around with just the simple gastroscope.
And you said the colonoscopy goes all the way up to the cecum, and that's as far as it goes. Is that right?
Oh no, you go to the cecum and then you tuck the scope into the terminal ileum, which is the
Terminal.
last part of the small intestine.
Okay. Has, I mean, endoscopy changed over time? I guess the earliest forms of endoscopy versus the modern procedures. I mean, I remember back in my day as a radiographer, the advancement I saw was pretty much that it used to be a TV. Sorry, it used to be they would look into
There,
the
look through
look
into
through
the
it,
direct scope directly.
yeah, directly into the scope. So, and now it's like there's a TV screen or TV screens up there. Has that been the
Mm.
main sort of change since its inception, or has there been other sort of changes?
They claim that colonoscopies were first done even back in the 1800s, but that was so primitive. I don't think it'd be recognizable to what we do today. That was sort of at the candlelight, and
Candlelight.
yeah, and then with light, and but just using something like a rigid sigmoidoscope through the decades, which would only really give you very limited insertion and limited views. And yes, you could have a look inside, but you couldn't do anything. You couldn't take any samples. And it was only in the late 60s that a couple of doctors from the Beth Israel Medical Center in New York by the names of William Wolfe and Hiromi Shinya invented the fiber optic colonoscope. And that was a huge leap in colonoscopy, and this allowed the gastroenterologist or surgeon to see the entire length of the colon. And then this then progressed. Dr. Shinya designed the first polypectomy snare, so you could go in and take a sample, remove a polyp.
It's interesting. It's not really a question I had to ask you, but you mentioned, there are obviously gastroenterologists that do the procedure of endoscopy. You also mentioned surgeons
Mm,
as well, and I'm assuming that they
mm,
have to just have some training in endoscopy to do that.
mm.
But there's also nurses, I think, too, that are doing it in some places. Is
There
that right?
are That's correct. There is some availability for specialized nurses to learn how to do colonoscopy. I'm not sure about gastroscopy actually as well, but definitely colonoscopy. The idea is the nurses would go into areas of need. I'm aware of a few nurse practitioners who do the colonoscopies.
I have seen that once, which I thought that's why it was a few years back. That was interesting.
Mm, mm.
What actually leads someone being referred for a gastroscopy or a colonoscopy?
With regards to the gastroscopy, the most common indications really would be reflux or heartburn. I just might point out that when we say reflux, that really refers to the the um, volume coming from the stomach up into the esophagus. So the regurgitation of that that volume into the esophagus, whereas heartburn is really the burning sensation.
Hmm.
So that's a very common reason to have a gastroscopy. Um, some people will have swallowing problems. That's
Hmm.
another reason. They might have had a test for celiac disease,
Hmm.
and it's suspected that based on that blood test that they do have celiac, so they come in for a biopsy. They might have pain in their stomach or feel nauseated.
Yeah.
And then with regard to the colonoscopy, again, many reasons. A common reason would be that they've taken part in the National Bowel Cancer Screening Program and they've had a positive test come back.
Hmm.
Some people have seen blood in their stool, or they've noticed a change in bowel habits, or they've had weight loss. Or some people simply have had a family history of bowel cancer or polyposis syndrome and so are presenting for screening.
Yep. Cool. And so, patient gets a referral from say, a GP normally. We're not talking in the
Mm,
private rather than the public, or vice
mm,
versa. And
mm.
so, what happens from the moment that they're booked, I guess, to the moment that
Yeah.
get home? What can a patient who might be listening going, I've got a endoscopy coming up, I don't know what to expect.
Yes. Well, so the standard of care now, if somebody's referred for a colonoscopy, would be that they have an appointment with the bowel prep nurse and they're educated about how to do a prep properly.
Mm-hmm.
Their medications that they take are reviewed and any adjustments are made.
Mm-hmm.
They're provided with the bowel prep to take home and given dietary instructions too on how they'll need to adjust their diet in the days prior to having the colonoscopy.
Mm-hmm.
And then the day before the colonoscopy, that's when they will stop eating food and just go on to clear fluids. And that's when they start the bowel prep. And the bowel prep occurs the day before the procedure and the day of the procedure. And then they'll be coming into hospital to have their colonoscopy on the day, meet the doctor and the anaesthetist is the doctor as well, but the surgeon or the gastroenterologist and the anaesthetist and for the nursing staff.
Okay. So, patients, I guess, what are patients most commonly worried about before an endoscopy? Maybe around sedation, discomfort,
An upper
embarrassment.
endoscopy, Jim, or a colonoscopy?
Well, we've just talked about we've talked about both, haven't we? So I guess endoscopy
Yeah,
in general.
I find the upper endoscopy, people are worried about gagging on the scope.
Hmm.
With regard to the colonoscopy, people the first thing that they're worried about is, am I clean enough? Is my
Hmm.
bowel prep good? Will the doctor be able to see?
Hmm.
I find that people aren't really worried about the going to sleep mostly. They're worried about if we'll be finding anything that'll be a problem for them, and yeah, if and with the bowel prep, sometimes they're a little bit nervous about and feeling embarrassed that somebody's going to be having a look at them. Um, and we just always try to reassure them um, that everybody's there to support them and keep them safe.
Yes, and it's done very professionally as well.
Absolutely.
They're not lying in the bed without any clothes. I mean, there is a lot of care
No, they're
associated with
covered.
privacy and dignity and all that sort of stuff.
There's actually hardly any of them that's exposed. There's a tiny little
Mhm.
window, and that's it.
Yeah,
Mhm.
yeah. You mentioned, so in terms of, I guess this is something that the bowel prep nurse would take care of. So regarding
Mm.
patients that are taking medications or supplements or anything like that, that's something that would be discussed beforehand. Is that correct?
Yeah. So what's really important for people to understand is that the quality of the bowel prep determines the quality of their colonoscopy. So
Mm-hmm.
if they don't have a good bowel prep, the doctor simply cannot see.
Mm-hmm.
So, in the days prior to the colonoscopy, that's when you're going on a low fiber diet with the importance of excluding nuts and seeds because they can hang around in the gastrointestinal tract for quite a long time and they block up our scopes, which is a real big problem because we can't wash and suck up the water as we're going. There are certain medications that need to be adjusted prior to the procedures as well, particularly the diabetic medications or any blood thinning medications. There are many different medications for both diabetes and thinning of the blood these days, and there's different instructions. And this is what the bowel prep nurse would be expected to be covering in the bowel prep nurse appointment because there's important adjustments because with bleeding being a risk during gastroscopy or and colonoscopy, we often will adjust any blood thinning medications to minimize the risk of bleeding.
Okay, that sounds fair. Let's talk about bowel prep. I think it's one of those things whenever I talk to someone about the procedure that's probably the most uncomfortable part of the experience.
Mm.
Um, what's in the bowel prep? And I remember reading something somewhere where because it doesn't taste pleasant. I mean, it's not undrinkable, but it's not the most pleasant tasting, and some people can feel uncomfortable with drinking it in terms of stomach feeling yucky and
And
what
yeah,
is it they can expect? Yeah, I mean it doesn't taste good. So what is in bowel prep?
bowel prep it contains salts really that will draw water into the gastrointestinal tract, and then by osmosis, then have that water come in and then flush you out. Um, Magnesium salts are common in them, and a few other things. There's many different bowel preps on the market.
Yeah.
Sometimes you might be drinking 3 liters, sometimes 2 liters. The bowel prep that I use with my patients, I've got two types. There's one called a low volume prep, and the patient is then only drinking 150 mils of prep the day before. Yeah, it's really low.
That's
And then
nothing.
no, and then 150 mils a day of. I must add the caveat that you are expected to drink water or clear fluids on top of that. So an
Yep.
additional 1.5, 2 liters of water in addition to the 150 mils, but that's okay.
That's nothing.
Um, yeah, and then other bowel preps, you drink a liter the day before and another
Yeah.
liter the day of. If you have a tendency to constipation, you'll need to drink more. Um, to help clear out the bowel properly. Um, yeah, and there's often sort of a few laxative tablets in the pack to get things going as well. So the drinks are quite salty. They often will have an orange or lemon or tropical taste.
Hmm.
That's really what it's limited to. Um, and I think part of what's hard with people getting nauseated is that if you've got a morning procedure, because you have to drink the bowel prep 5 hours before your procedure, say your procedure's at 8 a.m., you might be getting up at 3 o'clock in the morning to drink the bowel prep. And
Mm.
I think it's an assault on the system getting up at 3 o'clock in the morning anyway, and then having to drink
Yeah.
bowel prep on top of it. It's pretty tough.
I hadn't thought about it from that perspective. Yeah, that makes absolute sense. How does, I mean, what happens? I mean, if you're going in and it's like it's just yeah, they haven't done a proper bowel prep, and you can't
A common,
really see what happens. Do you just
yeah. A, a common thing that can occur is people drink the bowel prep the day before, and then they think they're clean, and then they don't drink the
uh,
full bowel prep the day of. But it's a false sense of security, because with drinking the second lot of bowel prep, you get sort of a second flush, and you'd be surprised at the second flush what comes out with that. So it's really important that you drink that, or the patient drinks both lots of bowel prep. If the gastroenterologist or surgeon looks inside the bowel and there's just too much residue in there, we you have to abandon the procedure, because the patient's there for a quality procedure, to have pathology such as polyps or inflammation detected. And if you can't see, you cannot offer a good quality procedure that is reliable to um, either to exclude or include a diagnosis.
okay? So the patients, there's no real way for the patient to know whether it's successful. I mean, if they're taking it properly as instructed, then there's a really high likelihood. If there's
Yeah.
still if there's still some stool kind of coming out, or that's, I mean, what are they looking for? They're looking for, like, I remember for me, probably too much information, but it was almost like clear bubbles. I'm like, is it like soapy or something? It was kind of weird, but
Yeah,
um,
that's
I
that's
was
bile
sparkling
salts that
clean on the
cause that
inside,
foamy.
but so
Yeah, you
what
get
is it
that
they're
foamy
expecting
appearance.
out when they look and they're looking in the toilet? I mean,
With a really good bowel prep, it should look like urine or
okay,
clear apple juice that's coming out. Sometimes it can mostly be liquid, but you might have little bits of residue there. Something, if you still have like a brown fluid coming out, that's an inadequate prep. If you realise that you've drunk all your bowel prep, but your bowels still don't have the output with a colour that is ideal, um, the usual instructions are to get in touch with the hospital or day clinic early and present earlier and drink additional bowel prep to really to get that additional flush through. Or sometimes we give an enema, and the majority of the time, if that's done all in time, the patient is able to have their procedure that day.
okay. Is there any recommendations that you make to patients to make that whole experience easier, or just
It's yes, I think that if you have the bowel prep made up and then put it in the fridge, so
yep,
it's really cold, and drink it through a straw, makes it a lot easier.
in a straw so you're not smelling it? Is that
You're just kind of sucking it down, just kind of scoots through your mouth and you're not tasting it.
It's funny. I remember watching an interview with Martin Short and what's his name?
Steve Martin.
Steve Martin, thank you. And a couple, I think it was a couple other people, and they would have a colonoscopy party sort of thing where they would they'd be playing cards, and I think the person that won was going to have the procedure first or something like that. So they have to, if they lost the shot, they would drink the glass or something. So they made that whole experience a bit more fun. And the winner basically went and had the procedure first and didn't have to wait as long, of course, because you're still fasting and so forth.
Yes,
Which
yes,
I thought was hilarious actually in that interview. I thought that was what a great way of changing something that might be unpleasant to something that could be potentially fun, and you've got your supportive
yes.
friends going through the same thing.
Yeah, those two are great.
Yeah, it's great. Okay, so the patient's at home. They've done the bowel prep. All right, I'm seeing apple juice. It's looking good. What happens
Yeah.
when they arrive at the day of the procedure? Who do they usually meet up with?
So they will always have to check in at admissions,
Mm-hmm.
and then they will be taken through, and a nurse will see them,
Mm-hmm.
have them change into their gown and hop into the bed.
Mm-hmm.
And then they will meet the anaesthetist, and the anaesthetist will have a chat about the procedure, any potential risks, take another medical history,
Mm-hmm.
and the anaesthetist will pop a cannula in their hand or their arm. And the cannula is a thin, flexible plastic that goes into the vein, and that's what the anaesthetist uses to deliver the sedation through. And then they will be wheeled through into the endoscopy room, and then it's all go. The anaesthetist gives the sedation, and the gastroenterologist or the surgeon will start the procedure. Of course, the gastroenterologist or surgeon will also come and say hello to the patient before they come into the endoscopy room, but pretty much that's the chain of events.
And I'm probably jumping up. We'll actually get to the recovery in a moment because there's a question I've got around that. But anyway,
Mm.
okay. So they're on the bed and the procedure is about to take place. Is there a difference between the public hospital system versus a private clinic in terms of endoscopy?
So when you go to the public hospital, the majority of the time, the anaesthetists are still giving the sedation. Sometimes there is proceduralist sedation. Um, so
What does
that
that mean?
when Yeah, so that's when an anaesthetist gives the sedation,
Mm-hmm.
it really is nowadays in Australia a deep sedation. So the patient is asleep, but they are breathing for themselves. The
Mm-hmm.
medication that the anaesthetist gives them is the same as what is given in a general anaesthetic, minus a couple of agents.
Yeah.
But the patient is asleep, but they are breathing for themselves. When you have a proceduralist, so the gastroenterologist or the surgeon giving the medicine, you have a medication for pain relief and a medication to make you a bit sleepy, but you are not, or a bit drowsy, I should say, but you are not asleep like you are when you have an anaesthetist giving you the deep sedation. There is uh, something that's come into practice now, and it's used up in North Queensland. It's called EDNAPS. So that's endoscopist directed nurse assisted procedural sedation. So the gastroenterologist or the surgeon is instructing a nurse to give the sedation
Oh,
during
okay.
the procedure. Yeah. And they've got some safety data supporting that. Um, so in when you are attending the public hospital, you are attending the hospital on the day that you're told to, and you are having your procedure. And you most of the time will have an anaesthetist, but you might be having the trainee doing your procedure or the gastroenterologist. Whereas in the private system, you're choosing who does your procedure, where they do it, and you're getting the fully trained doctor who's doing the procedure for you.
Yep. In Australia, it's quite common to have the procedure of endoscopy under sedation. Um,
Mm,
and I'm assuming in the public and private
mm,
systems, but
mm,
unless contraindicated. Um,
mm.
but you and I've had this discussion in the United Kingdom. I'm assuming this
Mm,
is during the public, throughout the public system. They don't
mm.
necessarily have anesthetic or anesthesia.
No,
How can you
no.
explain that? How do you explain the difference in? I feel sorry for those guys, but how would you explain the difference in that? I mean, they're completely conscious of having a tube down their throat and one up
Yes.
their backside, right?
Mm. They are. I think if there's a bit of a cultural thing that comes into it as well. They know that that is in the UK that that's the standard,
Mm-hmm.
so they're probably more accepting of it than we are here.
Mm-hmm.
But yes, Jim, I mean, you're awake, and so it can be a little bit trickier, I guess, for the person doing the procedure and the person having the procedure. There's no pain receptors in the gastrointestinal tract, right? So all the intestines, they don't have pain receptors, but they do have stretch receptors. So when the scope is going around curves or corners in the colon, it can stretch parts of the colon, and that stretch, and there are stretch receptors that gets relayed back to your brain as a pain sensation. So yes, that can be very uncomfortable for the patient. And it can also be um, painful or uncomfortable for them at the exit as well. So they really have to be trying to relax as much as they can. Some of them quite like it because they might go and have it done during their lunchtime with work, and then you're able to drive or walk back to work because you haven't had any sedation. So it's very convenient in that way. And sometimes I have done unsedated colonoscopy here in Australia, or flexible sigmoidoscopy, and actually a gastroscopy for people who haven't wanted the sedation, and they haven't wanted it for various reasons. I've done um, um, colonoscopies on people who wanted to remain awake because they wanted to drive home,
Mm.
or a flexible sigmoidoscopy, right? That's like a half colonoscopy. We only put the scope into 20 or 30 centimeters in. It's almost like just a sort of an extended digital rectal exam in terms of discomfort.
Mm-hmm.
A few pregnant patients I've had have been really unwell, and I've had to have a little look inside. So they've elected to not have any sedation because they felt that that was safer being
Yep.
pregnant.
Yep.
Um, yeah,
I get the colonoscopy and the discomfort. The gastroscopy is just harder for me to imagine.
it's really hard.
The swallow
Yeah.
a tube down and to have it basically, because you're basically moving it down and making some adjustments and so forth. I'm not trying to scare people that are listening. I mean, it's obviously they do it obviously in the UK quite routinely, and people manage perfectly fine. And there's also a spray that you put in the back of your
You do
throat as a
have,
prep, as a numbing.
that's right.
Yep.
Yeah, a bit of lignocaine spray to help
Okay.
with the gagging. But look, it is tough. It is tough with alone. You have to be very motivated, I think, to have a gastroscopy without a sedation. I agree with you, Jim. I if it was myself, I'd think I could get through the colonoscopy without sedation, okay, but the gastroscopy, I'd really prefer to be sedated for that one.
With the exception of those people that do theatrics and they swallow the swords.
Yeah.
I used to know someone that used to do that, which
Oh,
is
really?
yeah, yeah, yeah. So that for them would be like this is easy in
This is
comparison.
easy. Yeah.
So the patients now, let's assume they're under the anesthetic.
Mm.
What's actually happening during a gastroscopy and a colonoscopy? Well, from the patient's perspective, I think you pretty much suggested aspects of that anyway.
Yeah. So they're lying on their left-hand side on the bed,
Why left
covered
hand
in
side?
um the a patient is always examined from the left-hand side. That's how it's done. We always do that when we're examining a patient at any time. You always come in from the left. I think it's probably because the majority of people are right-handed, and so if you're leaning over the patient, you've got your dominant hand over them.
Okay,
So everything's
interesting.
really
I didn't know
structured
that.
for the right-handed person.
Okay, that makes
So they're lying on their left hip, left shoulder. They're
mhm.
covered in a blanket. We raise the blanket up a little bit so we can get access, and then the um, the scope is inserted, and then we have a monitor in front of us, and so we're watching on this monitor in front of us what's going on, and we're and the anaesthetist is they're watching their machine as well, making sure the blood
Machine that
pressure
goes.
is made at the machine that goes beep. Yeah, they're watching that, watching the patients. breathing. They're watching their chest go up and down, their oxygen saturations, blood pressure. Yeah, and then so we're watching the monitor as the scope goes around the colon or down into the stomach and the small intestine, and then we're looking for any signs of inflammation, ulceration, any polyps in the bowel, which are growths that can turn to cancer over time.
Hmm.
And if we find any polyps, we're removing those, or if we see any areas that we think we need to take a sample of or a biopsy, we do that. And when that and the snare that we use to remove polyps, or the biopsy forceps that we use to take biopsies, they're threaded down through the scope into the gastrointestinal tract, and then the sample is taken, and then we remove that. Um, Usually we allow about 30 minutes for a diagnostic colonoscopy and about 15-20 minutes for the gastroscopy.
So are biopsies always, I mean, you're talking about the snare or removing the polyps, and
Mm.
maybe touch on that first. Why are polyps removed? What are polyps? So people might not know what polyps are. What are polyps and why are they removed?
Polyps are growths in the colon or bowel, large intestine, that can turn to cancer over time.
Hmm.
That polyp to cancer sequence in general takes 7 to 15 years to grow the polyp and have it turn to cancer. There are a few exceptions, but if we want to
Hmm.
talk in general, that's the rule.
Hmm.
So when we see the polyp, we want to remove it before it turns to cancer to help to decrease the risk of that patient developing bowel cancer over time.
Hmm. Are you ever taking routine? Because in I'm pretty much going to be answering the question for you. Because in when it
Mm,
comes to gastroscopies, you're
mm.
routinely taking biopsies anyway. Is that correct?
We're routinely taking biopsies when we're doing gastroscopies, yes, and that is because sometimes there's pathologies that are more difficult to see. For example, there's autoimmune gastritis, celiac disease. Sometimes the villi can look normal, but then on biopsy, they are blunted, suggesting celiac disease. Um, and in the colonoscopy, there's a condition, for example, called microscopic colitis, where the colon can look normal when you're looking at it, but the diagnosis is made on the biopsy. So that's why biopsies are taken. I wouldn't want people to panic when they've heard that they've had a biopsy done, because it doesn't mean that if you've had a biopsy done that you've got cancer. Not at all. There's many other diagnoses that we're looking to exclude.
There's microscopic esophagitis too, isn't there? You don't. Is that a thing as well?
Eosinophilic esophagitis, lymphocytic esophagitis, and then we might be taking biopsies for reflux as well.
So multiple. So did you
Mm.
say that you do or you don't take biopsies of the bowel as routine if you don't, even if you don't see anything? Is there anything that really can, not really?
No, you don't always take biopsies of the colon if you um, unless there's a specific reason. For example, if it's one of my inflammatory bowel disease patients, I'll always take biopsies because I want to check what their inflammatory bowel disease is doing. We're aiming for them to get into full histologic remission now, which means that even the biopsies appear normal. There's no evidence of inflammatory bowel disease on the biopsy. But yeah, no, if they're well otherwise and they're coming in for a reason, when I say well, I mean they've not got diarrhea. They're coming in because they've maybe had a positive fecal occult blood test, or they've seen a bit of blood, or they're just having screening because of family history. Then I won't take biopsies routinely.
Okay. All right. So you've essentially gone through. We'll assume that it's a clean bowel. You've done all this. You've come up with a diagnosis. You've taken photos as well throughout the process. If
Mm.
you see anything,
It's
um,
standard practice to take photos to show that you've completed the procedure. Yeah,
yep. So that means if you found something or not, right? So whether it's clear or not, basically, if you see any spots of
correct. Because
inflammation,
you
obviously. Yep.
a standard of colonoscopy quality would be to take what they're called landmark photos to prove that you've completed the colonoscopy. So you've gone right round the colon.
Okay. And so, all right. So the procedure's done, and the scopes are taken out. This is, I know it's a
Mm.
funny kind of question that I'm asking this, but um, that some patients might not ask. But
Mm.
We're all assuming the scopes are cleaned, right? There's a bit of a running joke
Uh,
sometimes that go, I hope that's cleaned.
yeah. Do you know,
Right?
many
Or
many years ago,
it's not going, or the joke is, I've gone, like, make sure that it's the gastroscopy first and the
you
colonoscopy
first,
second if you're using the
yeah,
same
yeah,
scope, right? But
yeah,
and they are different scopes.
they
Um,
are different scopes. Yeah.
how are they cleaned between patients? And again, what do you do to ensure there's no risk of infection?
The safety standards for cleaning scopes are very, very stringent and are constantly being reviewed and updated. Um, the Gastroenterology Nurses Society of Australia is um, a group that has a big role in this, as well as the Gastroenterology Society of Australia. So the scopes are always rinsed and cleaned by hand to start.
Mm,
And then after they've been cleaned by hand, they're put in a cleaning cabinet. And so they lie in a tray, sort of coiled up, and then they're put on a cleaning cycle in the scope cleaning cabinet. Um, they're flushed inside and out, and cleaned, and then when that's finished, they're put in a drying cabinet.
okay. In terms of, so this has gone off to get cleaned, so forth. The patient's lying
Mm,
there.
mm.
What happens then? What happens to the patient after the procedure?
Oh, it's pretty easy. They cover back up again. They're wheeled out to the recovery.
Hmm.
They then are waking up from the sedation. They generally wake up very quickly. The medications that we use for the sedation for endoscopy are very short acting.
Hmm.
So once they are stopped, the patient generally will be waking up in a few minutes. And the comment from most people is, "Oh, I feel like I've had a really great sleep."
Mm.
Some people will tell you they were dreaming or
Mm.
they thought they were at home.
Mm.
And they're monitored for a few minutes to make sure that their oxygen saturations and blood pressure again are okay. Once they're well awake and the nurses are happy with how all of the observations are looking, they are moved over onto the second stage where they will get into their clothes and have that sandwich and cup of tea that everyone's very much looking forward to after starving for 24 hours while they
Mm.
drink clear fluids only for the bowel prep.
So it's eating is normal after the procedure?
Oh, yeah.
Does that
Unless
depend
there's a
on the,
reason not
yeah.
to eat, like that we've done an intervention that means the patient really needs to stay on clear fluids or stay fasted for a longer period.
Hmm.
People are always given something to eat
Yeah.
afterwards.
Yeah, I remember that. I think I've had a few over the years, but I remember one time I woke up and I opened my eyes and I looked around and I don't know where this came from, but I'm like, oh my God, they didn't do it. They didn't do the procedure.
Yeah.
They're trying to rip me off. And then I've
Yeah.
gone, actually, where am I? Hang on a sec.
Yeah.
I'm
Yeah.
sitting in a
Yeah.
recliner chair in recovery. I'm going, oh no, what? I've
Yes.
had it. That was just so, it was so bizarre. That I was just
Yeah.
like, they didn't do it. They're ripping me off. I was like, what? So that was my unusual, that might be my unusualness more than a typical thing. But other times it's usually like I'm relaxed and I'm asking for caviar and lobster afterwards. But I get a sandwich and coffee, so that's okay as well. So yes, they get a designated driver, and off they go. What are the symptoms that a patient might experience afterwards? Like, is there any discomfort? You mentioned earlier in terms of someone who doesn't have the anesthetic, but is there any other symptoms? Discomfort, bloating, whatnot?
Truthfully, when you wake up from a gastroscopy or a colonoscopy and you're sitting there, you're mostly fine.
Yeah,
People are fine. They shouldn't have any pain.
yeah.
Sometimes, if we've removed like a really large polyp, and can have a little bit of discomfort with that, and certainly if you've had hemorrhoid banding done, which is where we've used rubber bands to ligate hemorrhoids at the anus, you can have discomfort in the bottom um, from that, but you've been made aware of that beforehand. But in general, you should feel well waking up.
Okay. What are symptoms that might be considered to be red flags and that might prompt some medical attention?
Afterwards, if
Mm.
you have any pain afterwards that's getting worse, if you're having bleeding, if you spike a fever, if you're feeling faint or dizzy, they would all be unexpected symptoms, and that would be a reason to come back to the hospital.
Okay. We didn't mention, and sort of going back a step in terms of before
Mm.
we start talking about some risks and so forth, um, interventional endoscopy.
Mm.
What's that and why and where is that different?
Interventional endoscopy is really more advanced procedures inside the gastrointestinal tract,
Hmm.
starting from up the top during an upper endoscopy. There's procedures called per oral endoscopic myotomies now. That's where the interventional gastroenterologist might cut into the wall of the esophagus to treat a very specific
Achalasia?
type of swallowing problem. Yeah, achalasia, that's exactly right. Um, Sometimes stents are put in, which are metal coils to open up part of the gastrointestinal tract that's blocked in somebody who's very, very unwell.
Hmm.
Um, there's also procedures that the interventional gastroenterologist might do involving the bile ducts. Sometimes, if somebody's got stones stuck in the bile ducts, they'll be doing a procedure called an ERCP to open up the bile duct and let that bile drain so that the patient doesn't get an infection. So there's a few more advanced procedures, even removing very large polyps in the colon, that's considered an interventional procedure.
I used to do ERCPs. Did I ever tell you that when I was a radiographer?
Oh, did you?
Yeah, I was the radiographer taking the photos while it was
Taking
happening.
it. Yeah,
So
right.
back in those days, it was putting the cassettes in, taking the cassettes out, and then taking the films to be
Yeah.
processed. It shows how
Yes.
old I am.
I
Um,
suppose if you sort of think about it, the interventional gastroenterologists, they're doing treatments. It's a therapeutic procedure rather than a diagnostic
Diagnostic.
procedure.
So that's,
Mm.
I'm assuming that's extra specialized training and so forth.
That would you've chosen to go down that stream, and the length of training may not be any different from somebody who, for example, was doing a subspecialty in inflammatory bowel disease,
Okay.
but you've had specific training in those more advanced procedures.
Okay, that makes sense. So what, I mean, to someone who might be listening, is there's always risk. Would you say, would you call endoscopy invasive? It kind of is invasive, really, isn't
It
it?
is
But
an
it's,
invasive procedure. We're putting something inside someone's body, so it
yeah.
is.
What are the risks of endoscopy?
So if we again start at the top, an upper endoscopy,
Hmm.
there's about one in, if for a standard upper endoscopy, it's 1 in 5,000 risk of perforation. So that's creation of a hole in that gastrointestinal
Hmm.
tract, and about 1 in 1,000 risk of bleeding.
Hmm.
And then of course there's the anesthetics and anesthetic risks as well. For example, aspiration. So that's when fluid from the stomach comes up and the patient inhales it. That's a low risk. We wouldn't generally give a figure for that. And with the colonoscopy, a risk that a lot of people aren't aware of is that there's an accepted risk of 1 in 5,000 chance of damage to the spleen. And that's because the spleen sits such that the part of the colon comes right up and abuts it. And some people's spleen is adherent to the colon, or they're very fragile, and when the scope goes past, it can cause damage to the spleen. So that risk is about 1 in 5,000.
Hmm.
Risk of perforation with a standard colonoscopy is about 1 in 1,000, and risk of bleeding is about 1 in 100. They're the major risks that I speak to people about.
What about, I mean, I'm assuming you have, what about someone who might have, I mean, so diverticuli, which are small little out pouches
Mm,
across in the colon, little
mm,
pockets. Is there
mm.
increased risk of perforation? Is the diverticular potentially, you know, weakening the wall, or is that something that you need to be cautious of if you're aware of it? Or
Mm, just the presence of the pockets themselves in diverticular disease isn't an risk of perforation, but if somebody's had an attack of diverticulitis, meaning they've had an infection and inflammation of one of those little pockets, then the risk is increased. So after somebody's had an attack of diverticulitis, we don't do a colonoscopy on them for a good 4 to 6 weeks to give them time to heal and um, for that inflamed tissue to really settle down.
so I'm assuming that's for all things in terms of the screening before someone actually on the day or prior to the day, you're checking to see if they've got any ongoing infections and so forth. Is that standard practice as well?
Yeah, absolutely. For example, we wouldn't want to do a gastroscopy or colonoscopy on somebody who's got an active respiratory tract infection because the anesthetic risk increases.
What about? I remember sitting in with our colleague Professor Jeff Hebard
Mm,
while he was training some of the new grads or the
mm,
trainees, and they were talking about gastroscopies and the risk of varices rupturing. They're called
mm.
esophageal varices.
Yeah, so the varices are like varicose veins in
Yeah.
the esophagus. Varicose veins, like you see on people's legs, and so they're dilated veins in the esophagus, um, uh, generally in people who have liver disease, advanced liver disease called liver cirrhosis. And when those veins become very dilated, the walls are weak, and then they can bleed, and they can bleed quite spectacularly.
And what do you? I mean, I guess what do you, I mean. I know the question to this, but the answer to this. Sorry. How do you? Is that something that you're aware of? Someone does have cirrhosis that you're probably going and being a bit more mindful that there might be potential. I mean, you're also obviously going in quite slowly and cautiously, not just putting a tube down the throat really quickly or whatnot. I mean, you can see
Yeah,
what's happening as you're
unlikely.
going down.
Oh, yeah, you can see what's happening as you're going down. Yeah, you wouldn't be so rough as to upset a varix, I would think, when you're doing a gastroscopy. But that if with the liver disease, if you detect someone has cirrhosis, it's standard of care to screen for varices. So we'll do gastroscopies on selected patients with liver disease to see if they've got varices there that need treatment.
Yeah. The real question is, should the general public be afraid of having an endoscopy?
No, it's a low risk procedure overall, and with bowel cancer being diagnosed in 17,000 Australians a year and around
Mm,
5 to 5,500 Australians dying from bowel cancer
mm,
each year,
mm.
you've got a safe, low risk procedure that can change your life, really. If you have a colonoscopy and find a polyp and have that removed, and that prevents you getting bowel cancer, that's a fantastic thing. So people shouldn't be afraid of it.
Yeah, look, as I said, I've had a few over the time, and I don't know why. If anyone's listening that's a bit worried, I wouldn't really be worried. It's quite easy. You're under anesthetic, you don't remember a thing, and it's perfectly fine and reassuring. So I certainly
The
would like.
anesthetics it's the bowel prep. People don't like
Yeah,
drinking
that's
the
the
bowel
bowel
prep.
prep.
That's the worst part.
Yeah,
After that, after you've drunk the bowel prep, you've done all the hard work.
that's it. And of course, speak to your doctor if you've got any concerns. I'm not saying that you should go and have one. It's up to you to have one. Speak to your doctor.
Absolutely. We are
Um,
recommending that people adhere to guidelines and only have procedures that are recommended by
I
their
get
trusted
what
health professional.
has there been anything? I guess I'm kind of curious. Is there anything that's been a bit unusual that you've come across in terms of a procedure?
One of my colleagues here in Brisbane found a fly in a lady's stomach, which we all had a bit of a giggle at. There was an old lady who swallowed a fly.
A fly. Would that raises a lot of questions in terms of why wouldn't it
It
have been digested? Actually,
was dead. He took a lovely photo of it. It was dead, but it was whole. I don't know how she swallowed it.
well,
That was the
sometimes during the
funniest thing I've
night.
ever seen.
Oh, it's I can see sometimes you're running, night sleeping. Yeah, that's interesting. I do. So I've got another couple of questions. I'm going to go back because this is something I'm
Mm,
really curious about in terms of
mm.
testing. Can you tell? Can you test for lactose intolerance with a gastroscopy or endoscopy? And the second one, so I don't forget, is can you test SIBO or small intestinal bacterial overgrowth using endoscopy?
Mm. So we can take biopsies from the duodenum to test for lactose intolerance.
Mm-hmm.
With regard to small intestinal bacterial overgrowth, which is what SIBO is, no, we can't test that when we're doing a gastroscopy nor colonoscopy. To do that test, you've really got to have a breath test. There are
Sure.
there's some research being done where you can it's not generally used clinically, where you can take aspirates of the fluid from the duodenum and test the microbiome, but the data is not as robust as testing the microbiome from fecal samples, so that's not in general clinical use either.
Okay. Yes, I'm pretty sure I remember a patient of mine once telling me that they were told through a procedure, maybe it wasn't, I thought it was an assumption it was a gastroscopy where SIBO was confirmed, but through some form of scope. But
Yeah, I just
maybe
don't know.
maybe they didn't understand the process, maybe it was something else, but I was kind of curious about that.
Yeah, I'm not really quite sure how that would have come about.
Where are we seeing the development innovations in endoscopy in the future? I know that I mean, I've seen some stuff at conferences and so forth, but what are we seeing emerging, and where do you think it's going? A robot's going to be
So,
taking over endoscopy in the future?
oh, I think not in the near future. That not like where we have robots being used for abdominal surgery these days. What people
Yeah.
don't appreciate is it takes a very long time to set up all the equipment for a robotic surgery. And because
Yes.
colonoscopies are such quick procedures, really, it wouldn't make sense to
Yeah.
take an hour to set up a robot to do it. Um, Something that's widely available now in clinical use is artificial intelligence to increase polyp detection in the
Hmm.
colon, and that's something that we're using to it will flash up a little green box around anything that it thinks might be a polyp. Capsule endoscopy is something that's already being used that and has been used for quite a long time to interrogate the small intestine. And usually it's for to try and find if there's any sources of bleeding coming from the small intestine.
Mm.
Because as I touched on earlier, we've got 3 to 6 meters of small intestine, and we only see the very first few centimeters and the very last few centimeters when we're doing a standard upper endoscopy and colonoscopy. So that you've got all that small intestine in between that we don't see. And a capsule endoscopy, it's a tiny little camera inside a capsule about the size of a large multivitamin. And that goes down and it takes 4 photos a second and creates a video, which is then watched later. Um,
A full video?
there's all,
I didn't know it was a video. Sorry to interrupt you. I thought it was just
yeah,
snapshots of
oh,
certain points. Yeah.
because there's so many photos, it
Wow, that's
creates a
incredible.
video. Mm. And then we also have CT colonography now for people who are really high anesthetic risk, and we're not sure if they really should be having the invasive test. They can have a CT scan um, to interrogate the colon. They
Mm.
still have to drink bowel prep. You can't get away from that.
Mhm.
Um, and it um, it is only appropriate for a select few groups of patients. The other thing that really is an area that people are interested in is something called notes, and that's the treatment or procedures done on organs through the gastrointestinal tract. For example, removing an appendix through the cecum via colonoscopy, or they might look at removing gallbladders, etc. But that's sort of into the future. We've got really good laparoscopic procedures
Yeah.
presently, so yeah. But there are a few things that might evolve over time.
Okay. Well, that's interesting. I didn't know that. That's really cool.
Mm,
Obviously, increasing or reducing recovery time for patients, of course, is great.
yeah.
Which is what laparoscopy's done as well. There's no major abdominal surgery. People recover quite quickly. Um, is there anything that I haven't asked you that you think listeners might be kind of curious to know about anything we've discussed or related?
Mm. What let me have a little think. In the private system, people are often asking me how long it takes for the results to come back.
Ah, the
Generally,
results.
it's only,
Yes.
yeah,
Yep.
generally the results only take a few days.
Yep.
Um, uh, the pathology companies about are very quick in doing their reporting, so that's good. So, um, people want to know straight away if we can tell things. So, like,
Yep. Do you
if
see
we
them
say,
after? Sorry to interrupt you.
yeah,
This was really important because I was meant to include this as a question and I forgot. When the patient wakes up, are you there having a chat to them?
when they wake up enough that they'll remember
Yep.
me speaking to them, I absolutely go and speak to them every time. So, say they've had polyps removed, or say in those patients that unfortunately I have detected a cancer, um, we can tell straight away with that. It's and so we'll be able to give them those results straight away. With biopsies, that's when that takes a bit longer, or if we remove a polyp, knowing exactly what type of polyp that is, that testing takes a bit longer. But big things we can see at the time and we can tell the patient about straight away. So if we're able to exclude cancer, for example, which most people they who will come, they won't have a bowel cancer, yeah,
Mm.
we can tell them that straight away.
Okay. All right. Cool. All right. So that was the question about, do you have anything else that you want to add? Thank you for bringing that
Yeah,
up, because I was
absolutely.
actually to ask that, because like what happens once the patient finishes the procedure in regards to results. Um,
Hmm.
is there anything else, Nat, before we wind up for today?
I think we've covered quite a bit. It's a pretty good introduction to for somebody who doesn't know a lot about it.
Yeah, and of course, there's always a lot more details into everything. So this is just helping those individuals who are going, what does it actually involve? I'm kind of curious to know what the whole process is about and what to expect. And hopefully, this conversation today reduces some of that anxiety and uncertainty.
Yeah. Thanks for having me on, Jim.
Thank you for coming on. It's always great to catch up with you, and it's even more special today that we're doing this on a podcast. So thank you so much, Natalie, Dr. Kiel. Appreciate that immensely, and I look forward to catching up with you again.
Thanks so much.
Thanks.